For a man, it is easier to pick up 45 to 55 kg of a girl very easily, but for the same man, it is quite difficult to pick up 14 kg gas cylinder if his mother says to do this. Morale of the story is interest in the work matters. So, coming to the complication of the disease, fungus spread to infect toenails, feeding on the keratin in them which is present in the skin. A condition is called now onychomycosis. As it itch, it elicits scratch reflex. So the people do scratch, spread the fungus to the fingers and under the fingernails, so develop infection of the hands. From the hands, it can spread to wherever the person touches, like tinea corporis, the whole body involvement, and or tinea cororis, that is in between the legs, that can be seen because of this spread. Further scratching remove the scabs and inhibit the healing process. So by scratching, infected skin scales fall off onto the environment, clothes, socks, shoes, bathroom, etc., and infect the other people, those who come in contact with these things. Now, continuing the complication, they can also reinfect the host. Infected feet infest one's socks and shoes, which further expose feet to the fungus and its spores when the feet and the socks are worn again. The cracks lead to the bacterial skin infection, inflammation of the lymphatic vessels, and secondary cellulitis, osteomyelitis can even occur because of this infection. There is allergic response to fungus which is called an ID reaction. Here, blisters or the vesicles appear at the hands, chest and arms. Treating the underlying infection cause disappearance of the ID reaction symptom. So here one can see the Tinea Pedis in the feet that can lead to the autoexematization, that is a delayed type of the hypersensitivity reaction which is called ID reaction, and it resolves with the treatment of the primary infection because it has occurred in response to this Tinea Pedis. So one has to treat this rather than to concentrate on treating this. Now, coming to the diagnosis of the disease, there are 5 parts of the diagnosis. Number 1, history and clinical examination, wood light examination, wet mount preparation, KOH preparation, fungus culture, and the last is skin biopsy. First, we are going to deal history and clinical examination. History for the risk factors, medical history and the medical record is important. Clinical appearance on physical examination of the lesion or the visual inspection of the skin and the symptom such as itching of the affected area will also help. Number 2 is Wood's light examination. By this wood light lamp is negative because these dermatophytes do not flourish or shine as the other do flourish like the other dermatophytes. Third is the wet mount preparation, that is microscopic examination of slides of the skin scraping or nail scrapings that is seen under the simple microscope. The fourth is KOH preparation, that is called potassium hydroxide preparation. Here we place a tissue or sample on a glass slide and 10 to 20% potassium hydroxide is put on that. Potassium hydroxide dissolves the keratin to help clear the tissue and the fungus becomes naked. Gentle heating also dissolve the keratin and make visible the fungus. Now put the cover slip and place the slide under the light microscope and examine. So here, that is the Woods lamp, one can see the fluorescence if the dermatophytes are those which do have the quality of fluorescence. But here in this case, there is no fluorescence, and that is the negative wood light lamp. And here, how to prepare a wet mount slide. We put water drops and then the sample and put the glass slide under the microscope, and here one can see, when we see it under the microscope, we can see the fungus like this, as one can appreciate, and there are sometimes the bacteria also seen, as there is superadded infection. So that is wet mount microscopy. The next is potassium hydroxide preparation. Dermatophytes in skin scraping demonstrate multiple septate branching hyphae under the microscope. Next is fungus culture, that is the gold standard. Culture of the dermatophyte from skin scraping or from the infected tissue. Fungus grows slowly. Culture results are positive after 10 to 14 days, as one know that the fungus growth is always very slow, and we have this growth on Seborrheic dextrose agar. It provides identification of the causative organism by examining the form morphology of the fungus, which is different for the different fungus. And the last is skin biopsy. It is done if other ways, as I have already described, they fail, and we have to see the characteristic histological changes of this disease. And here one can see the potassium hydroxide test, as one can see that potassium hydroxide is going to separate the keratin from the hyphae, and one can see the hyphae, septate hyphae, that become nickered and the keratin is dissolved. Then we have fungus identification by having the culture, and we see the culture plates, and then from these culture plates we take the sample and do the direct microscopy so as to recognize that which type of the fungus it is. And here are the 4 different type of the fungi which are responsible for this disease, and one can see that the fungal infection of this type that can be seen. And here, if you do see this kind of the fungal infection, that is a characteristic of Trichophyton rubrum. And if we do see this kind of fungus, that is a microsporum. And here, if we see like this, that is epidermophyton flocculus. As I have already told you, there are 3 kinds of the fungi. Mainly, these are the met, that is Trichophyton, microsporum, and epidermophyton. Now, the differential diagnosis, diseases which mimic like this or which sometimes present like this, these are candidiasis, erythema, interdigital type, eczema, that is dyshydrotic type, psoriasis, contact dermatitis, pitted keratolysis, and lichen simplex chronicus. As one can see, the candidiasis of the feet, that is giving some picture like that, the Tinea Pedis, and here is erythema interdigital, that is also giving interdigital type of fungus, and here eczema, dyshydrotic, that is the plantar type, and here is also psoriasis of the feet, that also gives the appearance like that, variety of tinea. Similarly, contact dermatitis, as one can appreciate, and pitted keratolysis, and then lichenification, hypertrophied rough skin seen in lichen simplex chronicus due to the chronic itching and scratching, and there is also neurodermatitis. Here is the picture of the courage that the girl who is the mother and still she have the study and she has craze of the study and she is appearing in the exam with the kid in her lap. Now, coming to the treatment of the disease, it may resolve itself without medication in 30 to 40% of cases, and treatment which is being used, it is of three types: general measures, topical treatment, or oral or systemic treatment. First, the general measures take the necessary sanitation measure to prevent the spread and recurrence of the infection, not scratch the rash if there is. For itchy feet, soak in cool water, wash the feet daily or twice daily to get rid of the rash. Keep the infected feet dry and wear sandals will help in the treatment also. The other part of the treatment is topical treatment. If athlete foot is mild, use over-the-counter topical antifungal like andesinoic acid or tolnaftate, etc. Morning and evening BID for uncomplicated cases. These are available as ointment, cream, powder or spray. Apply all to the dry feet twice a day for 4 weeks and 1 week even after the rash is gone, so that there should be no recurrence of the problem. As the outer skin layers are damaged and prone to reinfection, so continue treatment till all layers of the skin are replaced and there is no cracked skin. Treat all infected areas, toenails, hands, torso, etc. Otherwise, reinfection can occur. So, here one can see andesinoic acid on the counter and also tolnaftate that is also available on the counter. Continuing the topical treatment, topical antifungal medication include butanafine once a day for 1 week or topical allylamine terbinafine once a day for 2 weeks is most effective but not suitable for the children. Clotrimazole BID or TID means twice a day or 3 times a day for 4 weeks, and miconazole morning and evening twice a day for 4 weeks. Iconazole twice a week for 4 weeks, and ketoconazole twice a week for 7 days, and also the tolnaftate twice a week for 7 days. Clean the socks by adding bleach or by washing it in the hot water of temperature 140 degree Fahrenheit so that it can kill the fungal spore and fungal. Dispose the infected shoes if possible. Plantar type athlete foot is resistant to the topical treatment due to the thickened hyperkeratotic skin on the sole of the foot, and the topical medication cannot penetrate this hyperkeratotic skin. Here, these are the topical treatments: butanafine and terbinafine, clotrimazole, miconazole, then iconazole and ketoconazole cream. These are available in different strengths and that can be used. Then use keratolytic and humectant like urea, salicylic acid and lactic acid as a part of the treatment of topical treatment. That is, to improve penetration of antifungal agents into the thickened skin. Topical glucocorticoid or steroid just alleviate inflammation and the itching. A solution of 1% potassium permanganate salt plus oxidizing agent dissolved in the hot water is very effective. For children, clotrimazole, iconazole, or miconazole should be used. Avoid the creams with the steroid, hydrocortisone. It helps the itching, but it can make athlete foot worse sometime. So here one can see tolnaftrate antifungal cream and potassium permanganate that can be very effective also with that. Now, the third part of the treatment is oral or systemic treatment. For severe, prolonged, refractory and persistent infection not responding to the topical treatment, or if the infection is at many places on the skin, oral terbinafine is more effective than griseofulvin, fluconazole or itraconazole. So oral terbinafine is the drug of choice that is taken once a day for 8 weeks. The adverse effect is gastrointestinal upset. It is contraindicated in pregnant women or the breastfeeding woman. In liver disease and also in children, it is not given. Also consider drug interaction with the other medicine, which is very much there with this drug. So here one can see terbinafine tablet, griseofulvin tablet, fluconazole capsule, and itraconazole capsule, which are the part of the treatment of systemic therapy. And here is the kit. If you are not able to take care of the kit and think that on the ground it is going to have just licking the hands with the dust, you can put it like the hanger on the wall. Now, how to get rid of the foot fungus? Home remedies are coconut oil, Epsom salt, baking soda, cinnamon oil, garlic, onion, listerine, vinegar, and foot soak that can be. And the last is prevention. Keeping the feet dry and adopt the good preventive foot hygiene measures to prevent and reduce the recurrence. Clipping the toenails short. Use a separate nail clipper for the infected toenails. Otherwise, if that is going to have the shearing, it can transfer the infection to the new user. Nail can house and spread the infection. Avoid tight-fitting footwear. Wear the sandals or well-ventilated footwear. Avoid the shoes made of synthetic material such as vinyl and rubber. These are not well ventilated. Avoid the socks or the shoes infested with the fungi. Use the socks made from the well ventilated cotton or synthetic moisture wicking materials, and the change socks daily. Use bleach in washing. Not put the socks when feet are not dry. Fungi multiply in flakes of the skin in unwashed socks. Avoid sharing of the towels, rugs, carpets, boots, shoes and footwear to prevent transmission. Avoid walking barefooted in the swimming pool areas, community baths, shower areas and a humid environment. Use the chlorine bleach, a disinfected and common household cleaner that kills the mold. Clean the surfaces with a chlorine bleach solution that it prevents the disease spreading from contact, and use of the topical antifungal powder or antifungals with antibacteria that also prevent. So here are the tips. Wash your feet, dry your feet and the area between your toes properly as shown here. Wear the cotton socks so that it can absorb the moisture. Wear flip-flop in the public moist floor so that you are not going to have contact with the squames on the floor, and do you have a 3-foot? So the patient is going to have burning, cracking skin, and the blisters and the red patches. So try to have all these things to prevent the 3-foot. And that is the end of the lecture. I hope you may like it. But if you like it, please subscribe it. I have given the maximum possible account of the disease, and I am sure one would not need to consult any other book after having this lecture. Thank you for the patience listening and watching.